Hey guys, so I wanted to go over the breast. The male and female pelvis are pretty self-explanatory, especially with the diagrams, but there was a couple things over the breast that I wanted to just go through. I'm going to just read over the PowerPoints and then I'm going to upload the video. So starting off, women and men both have breasts, so you will do ultrasounds on both women and men. They both have breast tissue. It's just women tend to have more breast tissue. Each breast lies over the muscle of the chest called the pectoralis muscle, pectoral muscle. So basically that breast is going to lie anterior to the pectoral muscles. The breast is an exocrine organ. Exocrine means that outside of the body. Main purpose and function is to secrete milk after pregnancy, known as lactation. The location of the breast, there's two of them. Typically they are going to be, again, this is going to be normal human anatomy, and anterior, the breasts are going to lie anterior to the pectoris major and minor muscles, anterior to the serratus muscles, and anterior to the external oblique. The medial border, and again medial to the body, is going to be the sternum, so that sternum area. Lateral border is going to be the axilla, which is again going to be your armpit, another name for an armpit, and then the tail of Spence. Tail of Spence is where up towards the axilla, basically the breast comes up to a little point. That point is known as the tail of Spence. Superior border are going to be the second and third ribs, and inferior border is going to be the sixth and seventh. Lies between the second and seventh rib, extends from the sternum to the axillary. Again, midline, medial landmark is going to be the sternum. Laterally, it's going to be the axilla, or again, lateral is going to be that tail of Spence. 2/3 of the upper portion of the breast is superficial to the pectoralis major muscle. The lower lateral lies on top of the serratus muscle. So again, the upper portion, the upper 2/3, is going to be anterior to the pectoralis major muscle, and then the lower portion is where it's going to sit anterior to the serratus muscle. Breast tissue, lobules. So the lobules are the glands in the breast that are going to produce milk, also are known as TDLUs. So the ducts are the tubes that carry the milk from the lobules to the nipples. So again, lobules produce the milk. The actual ducts themselves are going to go through and create a pathway essentially for that milk to be excreted through the nipple. Fatty and connective tissue surrounds the protective ducts and lobules, given its shape of the breast. That connective tissue are going to be known as Cooper's ligaments. Is going to be that connective tissue that you see within the breast. They have their own special name, and those breast connective tissue are known as Cooper's ligaments. Surrounds and bridge. So areola. Areola is the pink or brown circular area that surrounds the nipple. So it's just lateral to the entire, or outside of the entire nipple. Contains small sweat glands which secrete moisture that acts as lubricant during breastfeeding. So the areola is going to basically secrete some sort of lubricant during breastfeeding, whereas the actual nipple is going to be where the breast milk will come out. And again, the whole purpose of the breast is for feeding. So there's a cross-cut diagram, and again, that's where you can see the TDLUs, the terminal ductal lobular units, which have the Acini cells in it, the dense connective tissue, and that Cooper's ligament surrounding it, which again is that dense connective tissue inside of the breast that helps the breast maintain its shape and help it defy gravity, basically. Big one I wanted to go over was the 3 layers of the breast tissue. So the first layer, you see it's a little more hypoechoic. It's going to be subcutaneous layer, which is going to be that skin and fat. And then you have the mammary layer, which is a little bit thicker. So you have, in this picture, you basically have a really thin area at the very top, and then more of a hypoechoic area just posterior to that. That's going to be the subcutaneous layer. And then you see a little bit of a bigger, wider portion, anterior to posterior. I would say wider, a thicker anterior to posterior portion that's a little more hyperechoic. That's the mammary layer that contains the TDLUs, the connective tissue, Cooper's ligaments. Cooper's ligaments are going to be really, really bright typically on ultrasound, fibroglandular tissue, as well as ducts. And then the retromammary layer, you can see there's going to be in the image, there's it's a hyperechoic tissue, but then, or a hypoechoic tissue, sorry, but then you can see really bright white striations through it. It's typically just muscle for the most part. You do have ribs, which again, I think of what ribs look like. What are ribs, what are they composed of? They're bones. So typically when you see them on ultrasound, if you have them transverse, you're going to see a circular black portion on the screen, anechoic portion on the screen. And again, if you turn on it and you elongate it and sagittal to that rib, you'll see a big stripe down the back, again, where it's just going to be all shadow because we know that bone absorbs the ultrasound beams coming out. So again, that retromammary layer is going to consist of fatty tissue, muscle, the pectoralis muscles, both major and minor, ribs, cartilage, and deep fascia. And then again, those ribs are going to be the most posterior portion. And if you turn on them, they're going to be little circular structures. But again, if you turn on them and elongate them, you'll notice that it's a rib versus a mass. So normal variants, polymastia, that's extra breast tissue. That's all that is. Polythelia is an extra nipple, so supernumerary nipple, it's just an extra, typically non-functioning accessory nipple. They usually look like moles. Inherited is an autosomal dominant trait and occurs about 10% of the population, which means it's pretty common to have an extra nipple, third nipple, accessory nipple, supernumerary nipple. And again, it's typically non-functional. And you can see in the next picture what it's going to look like. And again, they look a lot like moles. The next slide is going to consist of different ways that we break up the breast. We talked a little bit about it in the intro, how we can document the breast in sagittal and transverse, but we also can use radial and anti-radial for breasts only. So again, the top portion of the slide shows the different ways you can break up the breast into quadrants. So you would want to know what breast that you're on. So let's say you're doing scanning a right breast, and then you would just go right breast upper inner, right breast upper outer, right breast lower inner, right breast lower outer. And so again, that's a very basic way. It's against 4 quadrants really, and it's when you're doing a big scan that's good. However, especially if you do find things like masses, and a lot of places are a little more particular, they do the clock method, and again, that's going to be different for each breast, whereas, you know, the 4 quadrants, you know, upper outer, lower outer, upper inner, lower inner. But the clock method is going to be a little bit different. So if you think about both breasts, at 12 o'clock and 6 o'clock, that's basically stating that that's the same area in both breasts. However, if you, let's say, go to 3 o'clock on both breasts, and it's backwards for you guys, for me, but let's say you go to 3 o'clock on both breasts, that's going to be, you know, the inner portion for one and the outer portion for the other. So if you're going through and you're looking, let's say you're looking at the left breast and you go to 3 o'clock, that would be the outer portion of the left breast. Whereas if you're looking at the right breast, and again, this is at the patient, you look at the right breast and you do the clock method where 12 o'clock is the most superior and you move, it would be the inner portion of the right breast. So again, make sure you understand the difference, because 3 o'clock on the left breast versus 3 o'clock on the right breast are going to be very different. The only consistencies in the numbers in the clock method are going to be the 12 and the 6 o'clock, because again, that's 12 o'clock and then the lower portion is 6 o'clock. And again, we use radial and anti-radial as well as transverse and sagittal. It just depends. And what I would like for you guys to do, if possible, to go through is, because I don't have anything to really show you, just go watch a little video on how radial and anti-radial is scanned. It's basically just slightly, it's perpendicular to either the nipple or it goes along. Basically, the point of it is to go through and elongate the ducts, because it's easier to see masses or any abnormalities in the ductal system. So go through and watch a little bit short video on just the difference between radial and anti-radial and how it's scanned. There usually you can find a short video on it, and I can even upload one. Actually, I'll upload a short video explaining radial and anti-radial. So physiology of the breast, estrogen. Initial development during puberty, so estrogen is going to go through and it's going to help develop those breasts. Development of parenchyma and stromal elements and are also what estrogen is going to inhibit, so the development of the parenchyma and the stromal elements. Progesterone is going to actually stimulate the breast lobules to develop, and then prolactin, which is produced by the anterior pituitary, stimulates lactation. So again, estrogen is what that causes those initial sex characteristics, breasts in females, and usually those are onset during puberty. So testosterone in men, estrogen in females, and then progesterone is going to essentially stimulates the actual lobules, the TDLUs. And again, prolactin won't be released by the anterior pituitary unless you're pregnant, unless you need to actually be lactating. and just the difference in the breast. So sonographic tissue, sonographic appearance, again, that nice little, reminds me of a cake layer, ultrasound with the different layers of the breast. I think that's a really good example. It's very easy to see the different layers. It's not always going to be the case. Again, fat is typically going to be more hypoechoic. The ducts, what do we think of any duct? What does any duct that we have talked about look like at this point? I'll give you a second to think about it. So think of the common bile duct, the ducts, the hepatic ducts. What do they look like? So again, typically they're going to be anechoic. They're supposed to be anechoic, and that's normal. Tubular structures. And then Cooper's ligaments, we kind of talked about that a little bit already. That's that dense connective tissue in the breast. It's going to be very bright, echogenic, and in a lot of people. It can be very thick. It can range from, you know, thin little linear lines to a little bit thicker. So kind of keep that in mind, that that's normal to have dense connective tissue. And again, that's going to be a little bit thicker of those ligaments, and they're going to be very, very bright. Parenchymal tissue is going to be medium to low level echoes, but they're going to be a little more hyperechoic to fat. So again, it's going to be that parenchymal tissue is going to be a little bit brighter than the fat. Nipple, when you actually scan over the nipple, because of the composition, it creates a shadow right in the middle of your screen right as you're going over it. So you don't really get to image the nipple so much. You can see posterior to the nipple an areola, but you have to do a little bit of angling because, again, that nipple does create a shadow. And then muscles are hypoechoic with striations, so they're going to have bright white lines, bright hyperechoic lines throughout the hypoechoic tissue. And then again, we have a third image of the actual breast tissue where you can go through and you can see the subcutaneous fat, the mammary layer, and then the retromammary layer. And then you can see a little bit, it's a little bit of a brighter picture, but you can see in the background, the very posterior end, where that's that little convex area of shadow, that would be what a rib would look like in a cross-sectional cut. And again, you can see the retromammary layer, really bright, nice, pretty striations. Breast cysts is a simple breast cyst. That's the next slide. I think if there's, so again, functional units are going to be the TDLUs, the ligaments of the breast are known as Cooper's ligaments. Both men and women have breasts. Go through, look up the radial and anti-radial method. Make sure you watch the video on it. But again, when we're talking about breasts, we go through upper inner, outer, lower inner, or we use the clock method, and then radial and anti-radial scanning, or transverse and sagittal. So if you have any questions, please let me know.